Welcome back, everyone. For those that may have just joined us, we've just had a little break for everyone to grab their coffees and waters and get assembled for the day. Just one thing I want to call out for those that might have missed the welcome session is that the chat feature, I think, is disabled. So if you would like to ask a question or make a comment, please use that Q&A feature there. So without further ado, we're going to jump into our keynote address. We have Dr. Laura Herrera Scott. We're very excited that she's with us this morning. She's currently serving Maryland as the Secretary of Health. Dr. Herrera Scott brings both public and private sector experience to the job. She's worked as a vice president at Anthem Blue Cross and Blue Shield, held the position of medical director of population and community health at Johns Hopkins Healthcare, and served as Deputy Secretary of Public Health under former Governor Martin O'Malley. Dr. Herrera Scott received her medical degree from the Downstate Health Sciences University in New York. She later got her Master's of Public Health at the Johns Hopkins Bloomberg School of Public Health. Before working statewide roles, Dr. Herrera Scott was the Chief Medical Officer at the Baltimore City Health Department. We're so pleased to have her with us this morning. And with that, I will go ahead and turn it over to Dr. Herrera Scott, Secretary.
Hi, Megan. Hi, good morning, everyone. Thank you for having me. Megan, I'm assuming you can hear me okay since I'm still having camera issues. Great.
I can hear you.
Well, good morning, everyone. When I was asked to speak at the conference, I was pretty excited because even based on my old life, we recognized very early on the potential of CRISP and partnered with them, not only on innovative new solutions, but more importantly, using those solutions to drive improved health outcomes for Marylanders. So what I thought I'd do is spend a little time going back and recreating that history and then describe in more detail what the partnership looks like today. Next slide. So I'll go over the history. I'll go over the Department of Health and CRISP as it relates to COVID, which was a turning point for the department, and then non-COVID related activities, and then what's next, challenges and opportunities, certainly as I engage in this role and things that I'm thinking about, how do we partner with CRISP to advance our data needs even more. Next slide. So a little bit about the history, just talking about Maryland and CRISP. In 2006, 2009 is when really CRISP started to grow. It partners with the Maryland Department of Health to plan a health information exchange for Maryland. And then it was very successful in connecting all Maryland hospitals and most providers to receive patient data. And this is key because we were early out of the gate in partnering with our hospitals. Many other HIEs have regional connections or rural connections, but Maryland was early in connecting all its hospitals. The department recognized the need for free flow of medical records, and CRISP, the Chesapeake Regional Information System for our patient, gets officially named as the designated statewide HIE. From 2010 to 2013 is really when the partnership started to develop, not only mandating the prescription drug monitoring program in the PDMP. We're one of the last states to develop a PDMP or to prove a law to have a PDMP. But that delay in getting us a program also afforded us the opportunity to embed the PDMP in the state HIE. In other states, their prescription drug monitoring program was a separate entity that you had to log in on, which had workflow implications for providers. We received the State Innovation Model Grant from CMMI, and that was one of the additional grants at the time that helped develop reporting and analytics tools to support quality programs. You can see also that CRISP started using point of care tools in their, specifically their query portal and their ENS. And then reporting services grew from 2014 to 2016. The department was finalizing its total cost of care model, and CRISP was developing PDM tools to assist providers as more and more tools came on, as well as working with embedding CRISP into EHRs. From 2017 to 2019, the total cost of care model was finalized. Again, CRISP was launching new reporting and analytics to leverage Medicare and Medicaid claims, as well as enhance its application. And then from 2020 on forward, state emergency due to COVID. And I'll spend a little bit of time going through all the solutions that CRISP developed to partner with the state. Next slide. So getting into the detail, I've talked about this a little bit more, but in 2008, CRISP was named Maryland's designated statewide HIE through a competitive process, and the first provider organizations are connected. The HRCRC then awarded grants, and CRISP wins the Federal Region Extension Center funding. In the early phases of CRISP, the focus was on identifying patient data and matching them together to create a holistic data set. So this is given all the ways that people were coming to into the system, the master patient index was key to really creating patient level views across the system. And as this evolved, CRISP developed point of care tools that could be used during patient care visits. HSCRC was one of the first early adopters of leveraging CRISP capabilities during this timeline, focused on utilizing hospital data available in CRISP to report on readmission quality metrics. Next slide. As I mentioned in the overview, this is when MDH really started to partner. So HSCRC was the first partner, and then MDH quickly followed. As I mentioned, with the prescription drug monitoring program, and that was through a Department of Justice grant that we got at the time. It made the PDMP data available to providers and dispensers alongside clinical data. It was in close partnership with the Behavioral Health Administration to support the continued development of the program and services. So we started thinking about how could we help providers use this tool to really help manage the patients that were getting controlled dangerous substances, for example, triggering for 90 MMEs, morphine equivalents, for those that might be at risk for overdoses. And then passed legislation that required mandatory registration and use. In addition to the PDMP, the Health Benefits Exchange, Provider Directory went live. And then the department was also using it for multi-drug resistant organism provider alerts. It enabled the public health ID team worked with CRISP to help identify patients that might be susceptible to these diseases. For example, C. difficile, and pushed alerts to providers for their awareness as they met with the patient. So as we were trying to deal with multi-drug resistant organisms, it was a way to alert providers of risks so they could manage their patients appropriately. Next slide. CRISP continues to build out essential infrastructure from 2016 to 2019. In context, was CRISP's embedded EHR application was launched. It also, again, launched additional reporting and analytics capabilities. It scaled up the PDMP functionality to support state mandates. Products were designed to support the region, and they were released as open source. And this was in line at the time when the HSCRC was funding regional partnerships. So CRISP was helping to inform those regional partnerships. And then the volume of clinical data that was moving through the system just increased. Next slide. So core services from CRISP to MDH, certainly reporting and analytics. CRISP provides secure access to Maryland healthcare data and related analytics tools to multiple programs within the agency. Demographic information enrichment, and this was key during not only COVID, but during our Maryland primary care program, to enhance data sources with race ethnicity from other data sources in CRISP to support health equity efforts. And then patient consent. It provides a patient ability to register consent to share data with providers that would otherwise be restricted. Next slide. So what did the relationship look like during COVID? Next slide. So CRISP really pivoted resources to help in the pandemic response. And that's when the partnership, especially around data collection, patient-provider connections, and data analysis grew. CRISP became a key infrastructure, or helped build key infrastructure to support the pandemic response and becoming part of a long-term public health efforts. Next slide. So what were some of those data projects? So patient referrals to treatment. So CRISP referral tool enabled providers to refer patients for monoclonal infusion. That is just one example. The demographic data enrichment for case reporting allowed MDH allowed data reported to MDH by providers, labs, and local health departments to be enriched with patient demographic information in CRISP, so race, ethnicity, zip code. And then that information was shared back with MDH as de-identified data to report to the CDC and to locals to inform their efforts. So for example, if COVID cases were flagged, if the patient address matches congregate facility or university rosters maintained by CRISP, so then it could be immediately routed for outbreak investigation. So these were real-time data connections, data aggregation that was happening that allowed the team to be intentional around where it was focusing its outbreak investigations. For the COVID hospital bed capacity, CRISP ingested daily data that MIMS collected from hospitals to provide statewide hospital capacity reports. For point of care testing, CRISP built a portal for other providers such as schools and skilled nursing facilities to report positive point of care tests for reporting into NEDS, which is the data system that we use to report to the CDC. For skilled nursing facilities, MDH was able to build its own reporting tool that CRISP built a portal for SNFs to report certain metrics to MDH for surveillance. And then, as already mentioned, for the usage of monoclonal therapies, it was a provider tool to report monoclonal usage and inventory. So not only could we make referrals to providers that were providing the monoclonal infusion, but then we could use it to track the usage and inventory of monoclonal therapies. Next slide. So now I'll spend a little bit of time on the non-COVID projects. But again, many of these newer projects were really born out of the work done during COVID-19. Next slide. So for Medicaid, CRISP has provided critical supportive infrastructure. So as I mentioned earlier, the Master Patient Index, portals and underlying infrastructure, Master Provider Registry, and the CRISP Data Lake all allowed many of the things that I'm going to go into now to happen. So if I think about care coordination efforts, starting with event notification, it allowed healthcare providers to receive real-time alerts when a provider's active patients had an encounter with one of the organizations sharing information to CRISP. So a hospital, a skilled nursing facility, or an ambulatory provider. And because that information was shared, it allowed for care coordination to occur. In some cases, deduplication of the effort related to care coordination, and ultimately improve patient outcomes. On the social determinants of health e-referral tool, CRISP has an electronic referral tool that enables healthcare entities, so again, hospitals and ambulatory practices, to refer to community-based organizations and receive information back. And this is key as we know social drivers of health and their impact on healthcare and healthcare access. And so understanding where people are going for these additional services, maybe for transportation, for food, for other services needed, it was a way for us to be able to track those services and understand their impact on the delivery of care. The pre-diabetes flag, CRISP uses data within its system to identify individuals who likely have pre-diabetes or a history of gestational diabetes. This information is based on ICD-10 codes, lab results, claims data, as well as information in the hospital and their data system. But this also allowed individuals to be identified, as well as referrals made for the Maryland Medicaid Diabetes Prevention Program. And it allowed MCOs to enable outreach and follow up with providers to support getting more members into the program. For image exchange, Medicaid opportunity providers have an opportunity to avoid unnecessary imaging study by accessing the images available through the image exchange. So if a chest x-ray was recently done because the patient was in the ER and then followed up with their PCP, it allowed that provider to see the image without having to repeat and thereby reducing unnecessary repeated imaging studies. The MOM program is a module that supports enhanced case management services for pregnant and postpartum Medicaid moms who have opioid use disorder. And so this strengthened linkages between the care manager and the clinical team by making the case management plan available to providers who follow MOM participants in CRISP, so that they could make sure that the details of the plan were executed once they were in with the provider. For the Medicaid CHIP, the lead asthma home visiting program, again in collaboration with CRISP, the Environmental Health Bureau and local health departments use this data to indicate when a child had moderate to severe asthma, had 2 or more emergency visits or 1 inpatient admission in the last 12 months, and it allowed them to conduct outreach to the child and the child's family for enrollment into the program, with the goal of not only providing education to the child and the family around which inhalers to use when, but also allowed them to assess allergens in the home and work with the family to reduce to stabilize the child's asthma, as well as reduce accessing the need to go to emergency rooms or being admitted because they were not well controlled. And then lastly, the skilled nursing facility expansion allowed for integration of the use of CRISP tools in supporting nursing facilities as part of the total cost of care model. So it expanded suite of technology and data connections that improved care coordination, disease surveillance, care transition among facilities, as an example. Next slide. On the Behavioral Health Administration, overdose-related data support, specifically around alerts and fatality review dashboard. So CRISP hosts the Overdose Fatality Review Dashboard, which assists local overdose fatality review teams in their investigations of overdose. The dashboard provides various information around non-fatal and fatal overdoses and insists in forming interventions to the substance use epidemic locally and statewide. The data are provided by the Office of the Chief Medical Examiner, Vital Statistics, Prescription Drug Monitoring Program, and the Maryland Institute for Emergency Medical Services Systems, or MIMS. So this was a way to pull all the information into one place so the local fatality review teams could use it to inform programming that they were doing locally. And it was certainly a capability that we did not have. And then the Data-Informed Overdose Risk Mitigation Project, or DORM. Some of you may be familiar with this as it relates to the opioid control center, and it links multiple state agency data sets that makes it possible for the identification of overdose risk factors and context between individuals who died from overdose in multiple health and social service systems. So it's the way we are tracking overdose data across different agencies and pulling that all together. So in addition to the public health data that I described in the first line, but how do we collectively look at the different information that may include police, corrections, as well as the health department to drive or reduce overdoses in the state of Maryland. Next slide. So public health has partnered with CRISP on many different initiatives. We've talked a little bit about the prescription drug monitoring program, not only in making data available to providers and dispensers, but certainly in close partnership with the Behavioral Health Administration and the work that they're doing around opioids, population health reports. So the CRISP has helped with geographic mapping for public health officials of hospital encounters and when married to HSCRC claims data for specific conditions. So this is akin to hotspotting. So as we think about where to deploy some of our interventions, these are some of the reports that are telling us where to deploy those interventions. Meaningful use is certainly an early use case, probably in the 2010 to 2016 range, but still continues. Support of the state medical examiner and fatality review teams. I shared a little bit about that in the last slide. Disease investigations, and highlighted a little of this during COVID. But certainly the work that CRISP has done has provided a much richer data source for hospital reported conditions than anything we had prior to CRISP. HIV care re-engagement. So it alerts that should be the Maryland Department of Health when HIV positive individuals encounter health system, but that reference to DHMH just shows you how old that relationship was with CRISP, and one of the early use cases in the public health world that we started partnering with CRISP. And then we use that information to reconnect individuals to treatment or individuals who had never learned that they were HIV positive. The Oz system was a newborn alerting to facilitate mandatory hearing screening. Caliper was a clinical quality measure calculation tool for Medicaid eligible professionals in hospitals using EMR data to automate selected clinical quality measures. And then our Immunet registry, which is where all our immunizations go, and it became available in the CRISP clinical portal, which again streamlined workloads for providers because they previously had to go and log into a separate system, but now could be all done in the Immunet registry through CRISP. Next slide. So other public health service projects. So the work with immunizations continue, especially as part of COVID, but then also developing additional use cases. The first of which is ImmuniTrack, which is a vaccine tracking tool, and it allows providers to see whether their patients have received COVID vaccine, but now we've added additional vaccines such as flu and pneumococcal. Immunization compliance tracking with schools. MDH is facilitating this with the local school system partnerships where, and this is still in play because of legal agreements that are getting put in place, but that school systems can share their rosters with CRISP so that CRISP can determine students' compliance with required school immunizations by reconciling data against Immunet. And this is really important, especially at certain milestones such as entering kindergarten and then I think it's 7th grade. And years ago, because there was no statewide way to track these immunizations, we had in certain jurisdictions thousands of children that were not allowed to start school because of their immunizations were not completed and or recorded. And so having this in place will allow us to work with school and school staff to ensure that children are in compliance with the required immunizations. And if they're not in compliance, that we are aware early enough that we can do things like set up immunization clinics in certain jurisdictions to make sure that no child misses the ability to start school because they haven't completed their immunizations. Infectious disease, we talked a little bit about multi-drug resistant organisms, but also using ENS for most recently Candida auris, and then using our Essence system on community-based epidemics, as well as referrals to local health services for mothers and infants as it relates to the MOM program, but other programs that we have in the maternal child health space. So what's next? And what are some of the challenges and the opportunity? Next slide. So new regulations require that the CRISP operate as a health data utility for the state. And, you know, I will share that in 2013, when we submitted our state innovation model grant, we wrote in 2013 the future use case for CRISP and the opportunity for it to serve as the data utility. So coming back to the state and learning that these regulations had passed were incredibly important to the work that we are doing moving forward, especially as we think about what we need to do to modernize our own data systems, but then how do we aggregate that data with the rest of the delivery system? So this was exciting news. And the purpose is all the things here to collect, aggregate, and analyze clinical information, public health data, and health administration operations data to assist the department, local health departments, the commission, the Health Services Cost Review Commission in the evaluation of public health interventions and health equity. And I know it's focused on public health, but it's really health and population health, and especially health equity. And the work that CRISP is doing on linking race and ethnicity really allows us an opportunity to start shining the light on race and ethnicity by age, by payer, by geography, as we work to improve access to care and equitable care for everyone. Certainly the communication of data between public health and healthcare providers to advance disease control and health equity, and the enhancement and acceleration of the interoperability of information throughout the state. I think with the work that CRISP has done and its designation as the state health data utility, we have an opportunity that other states don't have at this time, or if they have it, we have an opportunity to accelerate that relationship and the partnership in a way that will drive improved, or could drive improved health outcomes for Marylanders. Next slide. So what are the key pillars of a state health data utility? Certainly the services. Linking disparate data sets is not an easy task, but if we can do it, it'll allow the information to be more useful and drive outcomes that we haven't been able to do so far. You know, we often refer to the data that we have, or what we have, as being information rich but data poor, and so this is the opportunity to improve that. It would also allow for multiple sources to come together to fill gaps in our knowledge, improve data feeds, and as I already mentioned, surface key insights. It allows us to distribute information, so to create visualizations or control access levels that allow us to do things more creatively. So it not only improves the user experience, but then usage increases when a single entity is responsible for governance and distribution. And this is really important because then it becomes the source of truth. Oftentimes when you have different data sources coming together or different data being put out by different entities, people question the validity of the data, or their numbers look different, and it could be based on how it was pulled, when it was pulled, the filters they use or the assumptions that they built. But having CRISP as the state health data utility eliminates some of that work, because it's the data getting pulled together for one entity, bringing it all together to distribute the information. And then certainly it enables interventions to flag patients at point of care, notify appropriate end users, share relationships between organizations. And this allows not only alignment between population level reports, but actionable individual experiences, which are more likely to result in a positive change. So if we have, we could be thinking about interventions for specific individuals, such as our mothers using opioids and having individual outreaches based on the information. Or we could look at the data in aggregate and determine that in a certain area of the state, we have an increased number of moms using opioids, and could we deploy a community-wide intervention that improves not only connections for moms that are using into treatment and services, but improved health outcomes for the baby. So we are certainly thinking about this in a multitude of ways at the population level and as well as at the person level. Next slide. So what are the challenges with using data from the department? Well, public health data is dirty. And depending on where the data comes from, it can be incomplete, or not can be, is often incomplete. And so trying to compare apples to apples across jurisdictions or across certain fields can be difficult. There's certainly the need for a common data dictionary with matching data elements so that we can think about how to link these data sets from public health to behavioral health, including Medicaid, back to claims that are being generated. How do we start connecting to not only create the clinical picture for our population, but the social picture as well, based on the data that MDH has access to. And then much of the data that we do have access to is de-identified. So how can that be used to inform the data utility? And I think about that as we think about layers of information, with some of our de-identified data being the backdrop for how we think about the clinical information we know. So in the asthmatic program that I shared earlier, you could imagine using environmental health data with such as air quality, with ED utilization related to asthma, and overlaying an asthma utilization picture with environmental air quality, or pollen counts during the season with use of certain medications. But that's certainly the way we're thinking about this. Could we start layering this information in a way that not only paints the picture again for the individual and triggers for healthcare utilization, but then help us deploy interventions at the population level to improve health of communities that would then drive decreased utilization in more expensive settings. Next slide. So why is interoperability important? And this picture here is of the delivery system, but I wanted to keep it because we need to start thinking about that layer outside the core clinical setting to be inclusive of public health and community-based organizations and faith-based organizations and other entities that are all working to address the social drivers of health that impact any of these access points for a patient in the system. And as we think about that interoperability, how can we start thinking about automation of some of this information? So if we find reports are really informing outcome and enabling interventions in a way, how can we start automating that report and then determining who's best to see that report so that everyone that has a hand or a role in that patient's care, including the factors outside the core clinical delivery system, can start working to solve the issues for that particular patient or population of patients. Also thinking about increases in communication on care. So again, not only connecting the individuals or the stakeholders that you see in this slide, but perhaps a community-based organization that is providing community health worker services that's supporting that particular patient, that's also working on their transportation and working to get them food and helping them stabilize their housing, all of which then might impact their show rate in their primary care or follow-up visits in the hospital and or taking their medications timely. And certainly it's needed to include, as I already mentioned, public health and other social drivers to improve health outcome. Next slide. Now, what are we doing to be better partners as we think about how we'd like to integrate our work into CRISP? We are certainly working on modernizing our own public health data systems, some of which is very antiquated, but the team has done an incredible job of going through all our different data systems and starting to prioritize what are the best data systems that we have as we think about this interoperability that can help drive improved clinical outcomes. So, and how do we think about that data flowing into the system so that it connects clinical and public health entities in a way that they haven't been connected before. We're also thinking about it as a way to align policy and transparency around privacy, data use, and consent. I've talked about health equity several times, but that's certainly a priority for this administration, and thinking about what are the limitations in our data and how do we improve those limitations, such as making sure we're asking the right questions, reassuring people what the information is for, and providing education to the people who collect this information so that the field is not left blank or information is attributed based on perceptions, but that the data becomes more robust and is able to be used in a way that improves health outcomes for marginalized populations in the state. And that's inclusive of our rural community. And then how do we use it to facilitate collaboration across industries and stakeholders? So we know if we want to improve or develop more and more partnerships with CRISP and with the delivery system, we have to do a better job in making our data systems usable and ingestible for all the purposes that I've described today. Next slide. So what does the future of this partnership look like? We continue to build on all the things that I've described, and again, how will we be better partners? But one of the areas, at least in the 5 months that I've been in this role, that I don't think that I've seen and it may just be a limitation of, I just don't know yet, is the opportunity for predictive analytics. So as we think about all these connection points, how can we start using that information to start making inferences about what we think will happen, and then be more proactive and testing those predictions over time to see if they were accurate. For instance, we know that ACEs screening for childhood adverse events that scores greater than 4 contribute to, an increased diagnosis of depression and anxiety as adolescents and young adults. And so how do we take a score like that and use all the publicly available data that we have to see if that likelihood increases over time in certain zip codes, communities, school districts, so that we could be more intentional on where we deploy resources? Or thinking about preterm babies. So there was an article today in the Kaiser Family Foundation talking about using AI on the size of baby during gestation. Approximately 10% of all births are preterm, and Maryland right now, according to March of Dimes, has, I think, a D+ rating for preterm births. But could we use AI to predict who will have a preterm baby and intervene sooner for mom and baby to improve health outcomes? And certainly even thinking about aging. We have the total cost of care waiver. I think the country as a whole is unprepared for our aging population, and risk for Alzheimer's as an example. And how could we use predictive analytics to start identifying that population, and then developing programs that are impactful, as well as the intentional deployment of resources related to those predictive analytics. So lots of opportunity in that space. Certainly policy development, including planning initiative. CRISP has been a key partner and has now been named in many different bills and commissions as having a seat at the table. And so what is their ongoing role from their lessons learned and the information that they have and are sharing for policy develop and planning initiatives? And planning can be inclusive of urban planning to health resource planning, as I think about that, such as where to build new resources. Do we need a cancer center in a particular location, or there are other things, or a school-based health center in a particular district based on lessons learned from information that we're learning from CRISP? And then last but not least, certainly AI. Lots of different stories around AI recently, and whether it's good or bad, but certainly that's on the table for consideration as we think about how to improve the health of all Marylanders. And with that, I'll stop and thank everyone for their time, and take any questions if there's time. Kevin?
Thank you, Dr. Herrera Scott. This was super informative. We had a decent amount of questions about health data utility. I know we have a session later today dedicated just to that topic, but maybe you can speak a little bit about how you envision HDU being used, and what kind of benefits the day-to-day practitioner can gain from having CRISP be a health data utility.
So yeah, I don't know all the use cases the way the providers are using it now. I know providers are using it for providers that are in value-based payment arrangements. They're certainly using it to manage their patient population. But as I mentioned earlier, you can, as more and more information comes into the health data utility, besides managing whether or not they were admitted or in the ER, understanding again, geography and what's unique about a geography that impacts their health positively or negatively, and or where's their food deserts or pharmacy deserts, and what the impact of eating a well-balanced meal if they're diabetic or taking their medications regularly. So I think the sky's the limit as a use for a health data utility. And that is something that we will be spending time learning, not only as the state health department with multiple different units such as behavioral health, public health, even our own, we have 11 healthcare facilities, 5 forensic, 2 disability facility, and how our facilities are using that information to drive improved outcomes for the clients that we're taking care of. So I think there are multiple use cases, and then learning what those use cases are, again, to be as intentional as possible and build the tools necessary to drive what those use cases are. So more to come on that.
Excellent, thanks. And I want to just quickly thank everyone for asking questions in the Q&A, and we will try to answer all of your questions. If they're specific, Grace and I are going through and kind of coordinating with our CRISP staff to give you the best answer there. Laura, we had a couple of questions about nursing homes, assisted living facilities, long-term care, hospice. I think generated from the one slide where you had all the community there. Maybe you can just speak about the importance of those and maybe things that we can be doing better to improve communication across the health continuum to those facilities.
So, and those tools were built specifically during COVID, and it had to do with reporting certain metrics that we were using for surveillance. So not only is it related to positivity, but then outbreaks, but then those outbreaks and the implications for moving patients out of hospital, if they were taking new patients or not. I think the work is kind of lost a little bit of momentum, but certainly working with the entities that represent the skilled nursing facility and long-term care community on how to continue that work moving forward. Many of them at various stages of EHRs that can and cannot connect. And so working with the industry to pull that information in, because of the role that a skilled nursing facility has, let's say on ER wait times as an example, right? If we can't discharge patients, then patients that need a bed back up in the ED, but because we don't have visibility on the beds in skilled nursing facilities, it's sometimes hard to find the right place to send people. So that's work that is continuing, but much of the work that I described was done during COVID, and we are trying to keep those connections to continue that work and expand the use cases today.
Excellent, thank you. One other question. You talked a little bit about the future of partnership with CRISP. Some folks were curious if there are any other specific items that you wish CRISP would do more of. There's so many. I think CRISP could be used for disease registries, and how do we understand our population at the disease level. So you could imagine diabetes alone, de-identified, of course, but looking at back to the layering of information with public health that I mentioned, based on, access to food or access to pharmacy or access, where do they live? Is the community walkable, not walkable, public transportation, and make some inferences about healthcare utilization based on that.
even based on restaurants, for example, nearby, and what do they have access to, you know, if it's farmers markets, no farmers markets, supermarkets, you know, access to fresh fruits and vegetables, and what is the impact on diabetes. So disease registries could be one. I think even if we think about access to care. So I think better connections with primary care, who's going to their appointments, who's not going to the appointments, what does it say about the people not going to their appointments, and what are the lessons learned back to the predictive analytics of, you know, maybe if you haven't had a primary care appointment in the last 12 months, what are the implications for healthcare utilization elsewhere in the system, especially if you have at least one chronic, you know, condition. So I have a whole list of potentials that I think you could be working on, but those are just two to name. But we could be doing more with school-based health centers and the Department of Education in general, thinking about school absenteeism and what is the prognosis for someone that misses a lot of school, and how can we use that information to engage them, not only in school, but if they have a condition such as asthma, to stabilize their asthma in the system.
Dr. Herrera Scott, thank you so much for your time today. We really appreciate the knowledge that you shared and kind of talking about our partnership and what that partnership looks like in the future, and giving us some great ideas about the work that we can continue to do in partnership with you. So thank you so much for your time.
Thank you.